Good morning and good afternoon from Johannesburg. It's lovely to be with you on behalf of Maureen Dobbins and the COVID Engagement Working Group. It's a pleasure to welcome you and to have an exciting time together. So before Christian is going on with the main act, just a very quick background to COVID-End. We are a time-limited network who I think almost about a year ago around this time came together when the pandemic started, getting a bit active, and we had two main ideas: to support those who use evidence, to support those using evidence for COVID-19, and to support them in finding evidence and how to integrate it into decision making, and for the demand side. And at the same time, also supporting researchers who have produced COVID-relevant evidence on how to reduce duplication and to better coordinate. And it was quite a hectic time, and we very quickly came together and have grown into quite a big group now of over 50 organizations working in the evidence synthesis space, the technology assessment space, and also in the guideline space. And we are, among us, we're covering the full spectrum of different pandemic responses and have a very nice geographic spread. Next slide, thank you. And here's just a very quick overview of some of the organizations represented here. Next slide. So just very briefly, COVID-End, we engage in quite a few activities. On our website, you'll find an overview of all of these, and that's the first link there. And I think one of the key highlights are the inventory of best available evidence synthesis, a horizon scan of emerging issues, and also a community of practice of those supporting decision-making, the COVID-End community, which is supported by our working group in particular. And at the moment, that community, we have over, I think it's grown a little bit actually in the last couple of weeks. So probably have over 300 members now. And we have a listserv, and we also have webinars like the one today. And if you're more interested in participating a bit more in those, there's a link to the listserv itself, and you can also send us an email or join us on Twitter. And with that, I think my last slide would just to say many thanks to our funders for supporting us, and hope that gives a very, very brief tour to COVID-End. And I'll hand over to you, Christian, to give us the main content.
Thanks, Lawrence. Before we pass it over to Christian, I just wanted to welcome him today as our speaker. Christian Mansilla is currently a PhD student in the Health Policy Program at McMaster University and is a research assistant at the McMaster Health Forum. He dedicated an important part of his professional career to supporting health policy making processes using the best available research evidence. Through his work in this field, he contributed to the development and implementation of several policies at the Ministry of Health in Chile. He also founded and led the Evidence-Informed Policymaking Unit at the Ministry of Health in that country. As part of his professional experience, he has also been a consultant on a number of evidence-informed health policymaking and monitoring and evaluation projects for the World Health Organization. And now please welcome Christian.
Hi everyone. So thank you, Steve and Lawrence, for the introduction to this webinar. I'm excited to just get into that and just show you the first in one side the inventory of best available synthesis, and then the in-depth analysis that we have conducted so far in the existing evidence synthesis for the COVID-19 pandemic response. So yeah, I'm presenting today on behalf of the COVID secretary team that have been working in that. So a special acknowledge to Kaylan, James, and John into that. And I will be presenting this in two main areas today, right? So the first one will be a presentation about the inventory in particular, right? So it's just what is the inventory, how it was built, right, and how does it look specifically to make it useful for decision makers. And in the second half of the presentation, I would just explore an in-depth analysis of the evidence synthesis using the inventory to first give you a brief overview of what are the specific decisions that are being addressed by evidence synthesis and how the inventory has contributed to reduce the noise to signal ratio into that. Finally, I would just go to some specific decisions or some specific areas where the we could use the inventory to flag where evidence synthesis are urgently needed for the pandemic response. So yeah, let's jump into the first part, which is the inventory first. So the inventory is a repository of all the evidence, the best available evidence synthesis that is organized by four main type of decisions, which is public health measures, clinical management, health system arrangement, and economic and social responses. So we take like the number of evidence syntheses that are related to each one of those decisions and classify them as best based on how recent was the search of that specific synthesis, what is the quality of that review, and whether or not has a great evidence profile or not. Later, there's also a declarative title that it's provided to facilitate the relevant assessment into that, and also additional relevant that might be important for decisions, such as whether or not the evidence synthesis is living or not, if what is the synthesis type, separating in full review, rapid review, or protocol, and what is the type of research question that it's addressing. Sorry. Just like a brief and quick overview about the methods that we use to develop the inventory. First, syntheses are harvested from high-yield, high-quality sources of evidence, and primary data is extracted at that level. Then the eligibility, there come an eligibility assessment that is conducted in duplicate, where basically researchers evaluate whether or not the synthesis is relevant for COVID-19 decisions, if it search two or more database, and if it has explicit eligibility criteria to include the studies. Then filters are applied in duplicate as well, and just like each synthesis is classified as part of the COVID taxonomy of decisions that I will just explain in a minute. Later, the evidence syntheses are classified in their quality using the Amstar score. And finally, the best available evidence syntheses are classified per each type of decisions based on the recency, the quality of the synthesis. We are not considering we also used the quality to prioritize, but we are not including reviews with Amstars 3 or lower into the inventory. The availability of great evidence profile, as I said, and whether or not it's living or not the review. Finally, a declarative title is it's written for each one of the reviews that are included in the inventory, and are reworded by two other senior researchers to just like do a quality check in that step. So yeah, so then the taxonomy of decisions, it's a mutually exclusive and collective exhaustive list of type of decisions that are related to the COVID-19 response. And then it's organized by these four main areas that I mentioned before: public health, clinical management, health system, and economic and social responses. So in public health measure, it's separated in infection prevention, control, and broader public health measures. Clinical management is split in prophylaxis drugs to treat COVID, clinical management of pandemic-related impacts on other areas, right, in health, other conditions, and health promotion more generally. And then health system, which is like the approach to vaccination, the rollout of vaccination, population health management, and then delivery, financial, and governance arrangement. And economic and social responses, which comprises 20 different sectors that we are, for this presentation, we are just like group them in four main subgroups. So these are education and broader human services, social policy, economic, and environmental and energy policy. I just like put on brackets there the specific sectors that include each one of these big categories. Yeah, so I wanted to take a tour, but I just realized that how maybe Steve, you could just like help me how easy it could be that I share my screen to just like show my website into that.
You should be able to go share and then application.
Okay. Let me know if you're seeing my screen now.
Yep, we see your screen.
Okay, so I will just like take you to just like quickly show you how to take a tour on the inventory of best evidence. So this is the COVID-19 website, right? And if we go to the inventory of best evidence synthesis, you could see that this is split in the 4 main areas that I showed you here. So I will click in the first one to just like give a brief overview of the inventory, which is basically what I have just presented to you in the last few minutes, right? So I will just like click one example of these big areas of decision. So if we go to public health measures, we could see a reduced view here, but we could also expand to show additional columns. So I will go into that and we'll see like in infection prevention, we have the safety and efficacy of vaccination. We do have the date of last search for each one of the reviews that are including the quality using the AMSTER score, the availability of great evidence profile, the declarative title that it's here, which it's also hyperlinked to the original review that it's profiled here, whether or not it's living, the type of synthesis, type of question, and the final citation into that. So we have this for every decision in the taxonomy. This is, you're now seeing the public health measures. So yeah. Okay, so back into the presentation, this was the first part, right? Like about what is the inventory and how is it useful to just like make decisions or to inform decisions in COVID-19 response. I would like now to just like switch gears to go in a more kind of like a researcher analysis on research analysis in terms of like how what is the nature and what are the evidence syntheses that are currently being included in the inventory for COVID-19 response, right? So first of all, we have captured more than 6,000 reviews related to COVID-19 decisions, right? And this this is as per Monday, right? And like just removing for eligibility or duplications or duplicated, we have and we are currently assessing more 131. And over 3,000 reviews have been assessed and included in our like large database. And finally, 384 reviews, evidence synthesis, are currently being included in the inventory that I just showed you. So it is important to, at this point, I will probably just like mention this in the next few slides, but I will just like make the distinction here between these two boxes, right? So the database, the last two boxes, the database and the inventory. So first, I wonder if I can maybe, no, okay. Yeah, because like the database is the large data set which includes every single evidence synthesis that we have assessed as eligible for COVID-19 response, right? Whereas the inventory is the subset of that database that includes only the best available evidence synthesis. So that's important because I will just like separate and split the analysis in these two main buckets of data sets. So the first, which just like bring us to the first kind of like big important advantage of the inventory, which just like help us to, that it's highlighted in these two boxes, right? So it just like help us to go from over 6,000 evidence synthesis to only a reduced like 384 evidence synthesis so far in COVID-19 response. So it helps us to reduce the noise to signal ratio into that. And you could see in this graph that despite the number of evidence synthesis that has been increasingly growing in the last couple of months, right? And this is a trend that we could expect that could be maintained during this year, right? There's only a small share of synthesis that is included in the inventory and classifies as best, right? Then if we go to a specific topic coverage analysis of the existing evidence synthesis, if we focus first in public health and clinical management, we could see that over 2,000 evidence syntheses have been included in the database. Remember this large data set of all eligible evidence synthesis related to COVID-19 response. And like roughly 100 are addressing public health in the inventory as well. So, and most of these reviews are addressing either infection prevention or infection control decisions. So now if we switch to clinical management, we could see that over 3,500 evidence syntheses that are in the database are related to clinical management and over 200 in the inventory. And most of these are also related to either clinical treatment of COVID-19 or the clinical management of other conditions that are related to the pandemic, right? So my main takeaway of this slide here is that over this, around 70% of all evidence syntheses that have been produced for COVID-19 and that we have captured in the database for COVID-19 response, right, are related to one, public health, and two, clinical management. And if we go a bit deeper, infection prevention and infection control in public health, and clinical treatment of COVID and clinical management of pandemic-related impacts on health. So if we now switch to health systems and economic and social, probably the picture it's a bit different. So out of the more than 800 evidence syntheses that are related to health system arrangement, we are profiling only 37 in the inventory. And these are mainly related to delivery arrangement. With only 11 evidence syntheses that included in the database, and only one of them in the inventory that are addressing either financial or governance arrangements. So I would just come back to this point because I think that's one of our main knowledge gaps into this. And finally, out of the more than 300 reviews related to economic and social responses, we are including 31 in the inventory. 78% of the 300 are covered in education and broader human services and social policy, right? So we haven't found any reviews yet on environmental and energy policy, which is also a topic that I will just come back in a moment. Now, if we move to the currency of the existing evidence synthesis, and if we analyze the database, we could just see that, here I'm just talking about the search date of each one of the evidence synthesis and how in the past this was conducted, right? So we classified whether or not the review had their search date in the last 3 or 6 months. So 11% of the reviews that are currently included in the database, again, this large data set of all the reviews related to COVID-19 response, have conducted their search in the last 6 months, which is a very small percentage, I have to say. Then this percentage, of course, increased in the inventory, where 36% conducted their searches in the last 6 months, and 30% in the last 3 months, which is not surprising because we are including the best set of that database in the inventory, right? And then if we split this by specific broad decision, right? 85 syntheses that are included in the inventory under clinical management were conducted in the last 6 months, and only 4 syntheses in health system and economic and social responses their searches were conducted in the last 6 months. So the recent evidence syntheses are heavily concentrated in clinical management mostly. And if we also explore whether or not the synthesis was living or not, 123 living reviews that are currently included in the database have search data in the last 6 months, and over 100 of those are included in the inventory. So now let's go to what is the quality of the existing evidence synthesis included here. So around 77% of all syntheses that we have captured in the database have an AMSAR score 4 or higher. And only 21% of them have 8 or higher. So this is also we could just split that by broad level of decision as well. So over 800 have AMSAR score 4 to 7 in public health measured, and 278 8 or higher in public health measured. So over 1,400 of Amster score for 7 are included in clinical management, and 543 8 or higher for clinical management, which is substantially reduced for health system and economic and social responses again, right? Where only 332 reviews addressing health system arrangement have an Amster score 4 or higher, and 143 of economic and social responses have Amster score 4 or higher. So if we just like show what is the picture for the inventory, right? The 62% of the reviews that are included in the inventory have an Amster score 4 or 7, and 38%, the remaining 38%, 8 or higher. This percentage, this last 2% add up 100%. This is just because we are not considering reviews with Amster score 3 or lower in the inventory, right? So this is one way to just like help us to reduce the noise to signal ratio to select the best available synthesis. So now let's just like go, before we go to a more kind of like in-depth thematic analysis, I would just like to show the brief picture of what living reviews in COVID-19. And then over 9%, which is 200, we have captured 230 finished or ongoing living evidence synthesis that have been included in the database. So 62 of them are currently ongoing, and 27 have been also classified as rapid, and then the remaining 141 have been classified as full reviews. Out of them, the 147 are currently included in the inventory, so which account for the 43% of all the synthesis that we are including in the inventory. So yeah, this is like also something that I mentioned later, but the inventory is heavily relying on living evidence synthesis as a good strategy to keep with the evidence up to date in this constantly evolving world of evidence coming up, right? And how they're splitting in the main areas, the living reviews, right? So the vast majority of them are in clinical management with 111 syntheses here, and much less are included in public health, health system, and economic and social responses. Although what I should mention here is that we do have at this point living evidence synthesis in every group of decisions. So we do have in clinical management, in public health, in health system, and economic and social responses. Yeah, so this is the last part of my presentation today, that I just wanted to show like a more thematic analysis going like where do we might need some evidence synthesis because we haven't identified any for specific decisions into the taxonomy, in the COVID taxonomy. So first, going for decisions where we haven't identified completed or ongoing synthesis to be included in the inventory, and I split this again in the four main domains, right? So first, for public health, the pandemic tracking, we haven't identified any review that it's related to levels of reemergence that could trigger action for any given jurisdiction. Then for clinical management, we do have a lot of reviews on COVID-19 in pregnancy and like delivery, how this could just like affect when the patient got COVID, right? But not reviews have been identified in contraception and termination services under this area. Now the picture got probably longer for health system and economic and social arrangement, economic and social responses. So for health system arrangement, we don't have like we only have like one, I believe, like a small review into approach of vaccine rollout, but we suspect that this will probably evolve in the next few months, considering the stage where we are in terms of COVID-19 vaccination. So specifically on the delivery arrangement, again, a lot of review on the service planning for COVID-19 treatment related to scaling up and down the capacity for ICUs and ventilations, for example. Not many reviews about the scaling up, down the capacity of emergency rooms and post-ICU recovery. Yeah, so similarly, dead certification, handling dead bodies are also important categories that I wanted to highlight where no reviews have been conducted or have been identified for these big areas. And then in infrastructure planning and resource allocation, specifically under charter conditions, we do have some reviews related to the better use of PPE or ventilators for sick patients, but we don't have we haven't identified reviews on medication and other type of technologies for under charter conditions or disrupted supply chains due to COVID, right? And I said before that I want that I could get back to this final point, right? We don't have reviews on financial. We need reviews on financial and governance arrangement, particularly. And finally, economic and social responses were the first big sector, education and broader human services. We do have reviews on school opening and school closures and changes in school practices to prevent COVID-19, right? We do have good reviews into that area, but we don't have, or we haven't identified much reviews on instructor or student supports for this times, and online instruction as well, which is like something important to consider considering this time that we are living, right? And then in terms of the social policy, also religious institutions and practices, we have some reviews related to how risky it is to get into religious practices, right? But not many reviews addressing decisions in terms of like closing or like reducing capacity for those areas. Food safety and security, and also public spaces like parks, how like decisions related to this type of sector are also not included. And finally, these two main sectors, we haven't identified reviews that could be relevant for inclusion in the inventory, which is economic policy and environmental and energy policy, which is likely that we might see something in the next few months, considering the stage of the pandemic that we as a world are currently, right? Then the second element that the second type of like thematic analysis that I wanted to show here is a decision of the taxonomy where we do have available evidence synthesis, but where no yet living reviews have been identified. So this is just like to flag that potentially we might need reviews, living reviews in this area. And if any researcher would like to conduct a review in these specific areas, it's probably a better use of time if they conduct a living review instead, right? So again, I'm making the distinction in each one of the decisions here in between the database and the inventory. Again, the database is this large data set of all the reviews that we have identified related to COVID-19 response, whereas the inventory is the selection of that set related to the best available evidence synthesis for COVID-19 response, right? So in terms of vaccination, we have identified only 2 protocols that indirectly address the real world effectiveness of available vaccines, and they are both included in the inventory, but we believe that like this is a topic that where we urgently probably need some living reviews that could just like help us out during this year in terms of like the allocation and procurement of vaccines for any single jurisdiction, right? Then in infection control, we do have these 3 main areas, for example, contact tracing, where a large number of reviews have been identified. A small set of reviews have been profiled in the inventory, but not yet living reviews have been conducted into that. This is contact tracing, isolation of cases, and screening practices in general. If we go now to clinical management, so I'm picturing here the community-based treatment in the big category of clinical treatment of COVID, right? The community-based treatment, the management of some complications of COVID, such as cardiovascular or renal, are also like reviews with a large number of reviews included in the database and in the inventory, but not yet living reviews. And finally, proning position, which is something that it's commonly used. We do have reviews on ventilation, and we do have living reviews on ventilation, on mechanic ventilation, but we don't have living reviews on proning yet. And finally, the clinical management of the interrupted management or changes in the routine management of chronic or other type of conditions because of COVID, right? It's also a category of decision that is worth taking a look into that. And as per the health system arrangement, I just wanted to highlight here something that I mentioned before, right? Scaling for the service planning for COVID-19 treatment, we do have a lot of review for scaling up, down the testing and ICU capacity and palliative care capacity as well, but we don't have living reviews into this area. Also, for infrastructure planning and resource allocation, we do have reviews on PPE under shortage conditions and ventilators as well, right, for critical patients, but not living reviews on those areas from a health system perspective, right? And finally, we do have some reviews that are just trying to address how to move the health system back to normal, right, after the stress that COVID-19 has meant for them. But no living reviews yet again in this area of how to manage the wait lists, etc. And finally, economic and social responses, where it's probably an area where we don't have much reviews. This list is shorter because for most of them we don't have reviews yet, right? But for the areas that we do have some reviews, I could just mention service planning again to going back to normal. So reopening schools, reopening workplace, right? Where we have found some reviews related to that, but not yet living reviews into that area. And finally, police work and public demonstration in pandemic, which is something very relevant these days, right? And we might actually see something during this year. We do have some reviews into that, but not yet living reviews that I think it's critical to flag. So I'm just getting to the end of the presentation, so I would just show a few slides on the key findings and implications of this work, and how do we picture our next steps will be into this. So first, the inventory, it's a very useful tool to map where is existing evidence related to COVID-19 responses. It's a helpful tool to reduce the noise to signal ratio into this growing body of literature related to COVID-19. And it's easily access to it just provide that easy access to best available evidence for decision making in any single time. And it profile quickly where are the main living reviews in key decision areas, right? This is for more general for the inventory, but if we focus now in the analysis of the evidence syntheses that are included, we could say, as I said at the beginning, right, roughly the 70% of all evidence syntheses that we have identified are related to infection prevention and control in public health measures and clinical treatment of COVID and clinical management of the impacts of COVID on other health conditions in clinical management decisions, right? And the other key message that I could just take from this analysis is that evidence syntheses are getting quickly out of date, right? So we just mentioned that in that graph that only 11% of all syntheses were conducted in the last 6 months. The research was conducted in the last 6 months. So we urgent need either more living reviews that are highly now concentrated in clinical management, or more recent and high quality reviews, particularly for health system arrangement and economic and social responses, which are more where the quality and the reason is less accurate, developed probably. Then if we move to the second set of findings, is that the 43, the inventory is profiling the main available living evidence synthesis, which 43% of the total are living reviews, with the reviews that are included in the inventory, right? But these are, as I said, like mainly focused in clinical management decisions, although we do have living reviews currently. We are in a stage of the evidence world where we do have living reviews for every single type of decision in these 4 main areas, which is something good. And key areas where no evidence synthesis have yet been identified, and we urgently probably need some of them for this area, is pandemic tracking related to the re-emergence that trigger action, clinical management, specifically in the reproductive care for contraception termination services, health system for infrastructure planning and resource allocation, medication particularly, how they are disrupted for supply chains because of COVID, and financial and governance arrangement for health system, right? And as per economic and social, we also do need evidence synthesis on instructor and student support and online instruction, and also on food safety and security and public spaces like park and environmental and economic policies where no reviews so far have been identified in these areas. And finally, the key areas that I just mentioned at the end, where reviews are available, but no living reviews have been yet identified, are the real-world effectiveness of vaccination, the infection control, contact tracing, isolation, and screening, the management of some complications of COVID, proning and interrupted management or changes in the existing management of existing health conditions, right? And finally, for health system arrangement, again, areas where reviews are available but not yet living reviews have been conducted. It's like how to allocate PPE under charted conditions and ventilator for critical patients as well, and how to go back to normal with waiting list management and stuff like that for health system after the pandemic. And finally, for economic and social responses, something similar, and particularly for educational and workplaces, how to go back to normal, to reopening schools, to reopening workplaces after COVID, or after surge in waves, is something that we need living reviews into those areas. So this is my final slide of the webinar. I just feel that there are so many analyses that we can conduct with this data set. There are a couple of direct that we are not profiling here, but we could just do in the next few weeks, which is where the availability of evidence profile, right? Evidence profile, and the type of question that each one of the syntheses are conducted here, right? And also the characteristic of living evidence synthesis, right? The frequency of updates, where they're covering specific decisions, etc. We could just explore, and the nature of those updates we could also explore. Also, the match of the supply of evidence synthesis, right? That is reflected in here, right? In the database and the inventory, and the demand reflected in the horizon scanning work, that it's where are key areas where new living reviews are needed, right? It's something that we could explore in the next future. Also, a potential use of this analysis that we haven't been able to conduct yet, but we will in the next future, is to assess the potential duplication in these key areas, right? Large amounts of reviews where that are literally addressing similar or either exactly the same question, that we could just flag for researchers in the world to get an eye into that, right? And then specifically for the inventory, the inventory will that I just showed you in online, right, will eventually become a full searchable database. And these features that we are adding to the inventory, such as the classification of the best available evidence synthesis for specific decisions, are characteristics that could be potentially incorporated into existing databases and repositories of evidence synthesis, such as health system evidence, for example. So yeah, I just like want to finalize just to acknowledge all the high yield, high quality sources of evidence synthesis that provide us with the best available reviews for COVID-19, and also the staff and students that have worked in the back end of the inventory that have made this work possible into that. Thank you.
Thanks, Christian, for a great presentation and a really good overview of the inventory and for how the inventory can be used to help inform many of the decisions that policymakers and others are facing regarding the COVID-19 pandemic. We do have a couple of questions in the chat, so and certainly would encourage other people to ask their questions in there as we address these ones. Before we get started into that, a recording from this webinar will be posted on the COVID-End website in a couple of days. And I have also posted a link to the inventory in the chat so that everybody can go and check that out as well. So one of the first questions and a comment is from Kate. She says, great resource and talk. And then her question is, as a public health librarian, she's been following the BESI collaboration scorecard of trials, which tracks COVID-19 drug trials versus trials of behavioral, environmental, social, and systems interventions to reduce COVID-19 transmission. The imbalance is huge. Currently 2,155 registered drug trials versus 13 BESI trials. Do you see a similar dynamic in the evidence synthesis literature?
Well, thank you. Sorry, I'm just like trying to. Yeah, thank you, Kate, for the question. I think it's just like a big issue of how drug trials are kind of like driving like all the evidence synthesis world as well, I think, right? So I believe I just like presented also like how the reviews are mainly concentrated in the clinical management area, and I could just like say if we go deep, I could just like show the data, but that like most of those reviews are related to drug treatment, right? But I suspect, having said that, right, like this is something that is probably not new, right? We often expect that systematic reviews before COVID as well have been mainly conducted in the clinical area and specifically in the drug treatment for any single condition, right? And I think like COVID has probably exacerbated that trend. But I believe in this year, the situation might be different because drug treatment for COVID might they have not showed like an important effectiveness of their use in for COVID patients. So eventually, like and second, like because of vaccines, right? Probably the clinical shift or the research will shift to vaccination instead of drugs for COVID-19 treatment. So I expect, again, like, so just like to probably answer the question, I would say that, yeah, I agree with you, like that there's a similar dynamic in the evidence synthesis literature that is highly concentrated in drugs and clinical treatment. But I do expect that this situation will change as we shift the decision-making attention from drugs treatment to other type of decisions to address COVID-19 pandemic over this year.
Thanks, Christian. Diana asked if you could please tell more about occupational health and safety management systems in the enterprises.
What do you mean by more? Just or what I just like presented, or just like what do we have for that? Can maybe Diana
I'm not
speak?
sure, but Diana, if you want to clarify in the chat box, not the Q&A box, that might be helpful. As she says, what you have, I guess what you have in the inventory.
I could, but it could probably take me more time. So I could be happy to just like send you I don't know, like either a list of the reviews that we have found for that specific type of area, or just like I don't know, like a main takeaway of what are the specific reviews on that specific area. But as I said, it's probably like I need to dig into the inventory to just like see that. But I'm happy to do it, Diana, if you want.
So Diana, if you would like to follow up, perhaps email us at forum, forum at mcmaster.ca after the webinar, and I can connect you with Christian. Janice has I think it's more of a comment, but she said that many feel that using terms like back to normal should be replaced with post-pandemic structures and systems, as pre-pandemic normal was not optimal nor always equitable or inclusive.
Yeah, I think that's a great comment, Janice, and thank you for that. We'll definitely consider to just like our language of how the taxonomy is structured. Thank you.
And John also has a comment and question. So the key take-home messages: uneven coverage of decisions and lack of currency of even many best evidence syntheses are quite disheartening a full year into the pandemic evidence response. Do you, Christian, or others participating in the webinar have ideas for what we need to do better or differently to achieve greater coordination across the evidence synthesis community? So Christian, if you want to answer that, and if anybody else has comments to add into that, then perhaps just share them in the chat box.
What is your tab for you? I'm just reading it to just like better. So what I could say is that to achieve like a greater coordination across evidence synthesis community, I could say that like to flag the main, so I think like my second half of the analysis that I presented in this webinar was like more of a specific thematic analysis, or where do we urgently need reviews, right? And where we might potentially need living reviews, right? So I think the inventory has a great potential to show this area to the research community, to the evidence synthesis community, and this could be heavily, like importantly used for them to prioritize the area where we do need like more reviews, more high quality reviews and recent reviews, and where we do need living reviews to answer specific questions. But it could also be helpful, and I didn't get into that, to just like show where potential areas of duplication, of redundancy of different groups, just like to flag those areas to the evidence synthesis community, and to just like just like warn them to not prioritize those areas, because we already do have lots of reviews in those areas, and we might potentially have already living reviews in those areas. So it's a topic that it's already being explored and analyzed from that perspective. And I think like providing these inputs into the evidence synthesis community could just like help us out in the coordination across different actors in this community. But I don't know, like I'm probably not the best person to answer like the coordination across different actors. I don't know if Lawrence is also on the line, or is he just like went away?
He had to leave, Christian. So
okay, yeah, that's okay. Yeah, I would love to hear from him that specific question, but yeah.
Thanks, Christian. So Matthew also shared a comment. He said the lessons he's learned from the pandemic is that we have a lot of opportunities to bring evidence and evidence-based practice to health systems, organization, and process of care, not just diagnosis and treatment. He sees from your analysis that evidence synthesis is often lacking in reviews of these topics. He thinks that's because the interventions and outcomes are so heterogeneous. Devising ways to synthesize stronger conclusions from reviews of these reports would have a great impact on the quality and value of care.
So I think that's a great point, and thank you, Matthew, for just raising it. That I see that there's a difference, like between the two parts, right? Like, so there's one where a research team decide to conduct a review in a specific area, right? And then there's the result of that research process, which is like in the case of a systematic review, it could be that the results are very heterogeneous or not very clear at the end of the review, right? So I feel that like uncertainty is something that we need to live with, right? It's something that it's not necessarily going away, even for specific drug treatment. And it's something that we, in the evidence synthesis community, we just like live every day with that, right? But what I what I feel is that like that that the outcome it's often uncertain shouldn't just like stop us to conduct reviews on those areas, because there's still value to know what are the broad like broad results, or what are the broad primary studies that have been conducted for each one of the specific decisions, if that helps to clarify.
Thanks, Christian. We have a couple more comments that I think I'll just read out, and then some more questions. So Kaylin says, hi, John, your comments in Christian's slide about the need to dig into the alignment between the current supply and what is known from horizon scanning strikes me as something that may send signals about a potential disconnect too late in the process, i.e. the resources have already been used and the reviews are already done. Something that Christian may want to consider is priority areas signaling by funders, including governments, which won't always be publicly available, but could be fodder for a very insightful qualitative study. And Nuri commented that as a student employee at the Impact Lab, she really appreciates the insight into the database that they've been contributing to for the past year. It was especially helpful to see knowledge gaps in our database, for example, financial and governance arrangements reviews. Thanks, Christian. And then she says, thanks for the great presentations. She has some comments and questions. So she totally agrees with that we should follow the frequency of updates for living reviews, not only focusing on literature searched in the last 6 months. And then for Amstar score, do we only focus on the reported items? And for some items that the evidence syntheses are not appropriate, or the ratio of reported items reported items or overall items. How many evidence syntheses are preprints? What are the implications of the preprints, and do we track the completion of the protocols for some research, for some decision and research gaps? Do we consider conducting some evidence syntheses or collaborating with some evidence syntheses producers? Ooh, there's a lot of questions. I think, Christian, you can read these questions on here as well. So I'll maybe just let you go through them and answer them rather than continue to read them.
So thank you, Shi, I think they're just like helpful question into the process, and I think there are some of them are probably very specific into like what are the specific characteristic of the evidence synthesis that we are including. I could probably concentrate on your question 5, right? That it's something that and just like to relate with Kaylan's comment, right? So I think there is a potential, like in the COVID products, right, to raise whether the main areas where knowledge is missing or when living reviews are needed, right? And we could just like probably profile better that early in the process, as Kaylan said, right? To just like not get like too late where, oh, we already got like, I don't know, 100 reviews on that area, right? So we just like got late to avoid duplication. And I think that's a great potential that we could explore collaborating with our other evidence synthesis producers such as Cochrane or others in that area. So I think that's important to consider, and I think it's a great point. If you want, we could also get back to your specific questions about Amstar score preprint, because I don't know, I just like feel they're too specific to go into that right now, but I might be wrong, I don't know. Just like for sake of time, I think, if that's okay. Yeah, right.
Yeah, that's fine. Thanks, and you can follow up with Christian after to discuss some of those things. Although I think her last question, number 6, Christian, is also interesting about whether we consider using some visualized format to show the analysis of our inventory. I know a number of other groups have started using some visualization maps and different techniques to kind of graphically show the amount of evidence in certain areas. Do you think that's something that would be, helpful in this case, or is there other tools you've seen that might be of interest?
Yeah, I think so. So the like what just like came to my mind with that is just like COVID NMA map of drug trials for COVID-19, right? And I think it's a very helpful tool. I don't know, like here we need to just like also kind of like balance like the use of time on this, right? I think the inventory has, from my perspective, like using the time to identify decisions mainly, right? So what are relevant for decisions, and I think like to keeping on a nice visualization of where is the main evidence where the main evidence synthesis could help researchers to focus into that, right? But not sure how could help decision makers, policy makers, etc., right, into that. But I see that could be nice to just like provide a living visualization of where main evidence synthesis are, where the main gaps that we need to fill for the evidence synthesis community. Yeah, so thank you for that comment, Chi. I think it's important if we could just like move into something that could be more friendly to show.
Yeah, and Christian, that's a fair point. With the COVID inventory being updated on a weekly basis, it would be a time-consuming task to update the visualization to go along with it as well. But that's good. I don't see any other questions coming through in the chat right now. And we're almost at the end of our time for our webinar. So I'd like to thank everybody for the great discussion and great questions that have come through. And especially thanking Christian for his time today and for a great presentation about the COVID end inventory. So thanks very much, Christian. Thanks everybody for joining us, and look forward to having everybody join us in future webinars. Thanks a lot and have a great day.